let us begin with our session 1, that is approach to chest pain in the emergency by Dr. Niharika Aneja. Dr. Niharika Aneja is an associate consultant and head of the department in accident and emergency care. She completed her DNB in emergency medicine at Manipal Hospital's Old Airport Road, where she gained extensive training in managing both adult and pediatric emergencies. With expertise in trauma, oncological emergency, and cardiac and medical emergencies, Dr. Aneja practices the latest evidence-based medicine and advocates for comprehensive, holistic, multidisciplinary approach to the patient care. Her area of interest include trauma, toxicology, point of care, ultrasound, and she emphasizes situational awareness as a critical first step in emergency management and actively teaches skills to identify, process the emergency. Dr. Aneja earned her MBBS from Kasturba Medical College, Mangalore, and she is an active member of Academic Forum of Karnataka Emergency Medicine Group. Passionate about education, she regularly conducts training programs for nurses and doctors. Additionally, she has completed a post-graduation diploma in medical law and ethics from the esteemed National Law School of Bangalore. So I welcome Dr. Aneja ma'am for a wonderful session.
Thank you so much. Thank you for having me. Can I start the session?
Yes, ma'am, sure.
Thank you. I hope this is visible.
Yes, ma'am, it is visible.
Thank you. So the topic given to me is very dear to my heart. It's approach to chest pain in ED. We'll start with a case. So keep in mind these two cases when we go forward. So this is a Mr. XYZ, is a 50-year-old male with past history of hypertension and smoking. Was presents to the ED by ambulance complaining of first ever episode of severe crushing chest pain that just started while he was running on the treadmill. I have just highlighted what are the important points when you are taking a history, when somebody has come to you, or when you are reading, a case. Please remember to keep these points highlighted in your head, because these points are very important. The age of the patient, uh, what are the comorbidities, what was the patient doing when the chest pain started. It's very, very important. So Mr. XYZ was diaphoretic and moderately ill appearing. Pre-hospital treatment, he had received a nitroglycerin 0.4 mg sublingual, and still there was no change in pain. As you guys can see, the vitals, which is noted by the EMTs, looks almost all right, except the respiratory rate a little higher, on the higher end, but otherwise nothing abnormal as such. Your blood pressure, your pulse rate is all fine. Okay. Next, we'll know about another case. Well, this is a 69-year-old female with history of hypertension, which presents to emergency via triage, complaining of worsening of shortness of breath, chest pain and epigastric pain since last 24 hours. So it's a day history. That was more acute. Here it's a day history. She has nausea, vomiting, weakness, and fatigue. She feels terrible. She's ill appearing, and there's no medication that was given by the pre-hospital. Okay. So keeping these two cases in mind, we will go forward with our presentation. So remember, chest pain is one of the highest risk chief complaints that you'll see in a emergency department. However, diagnosing the etiology of acute chest pain in an emergency department can be very, very difficult. Because neither the quality or the intensity of chest pain can point towards a specific organ. It can be very confusing. So remember to keep in mind the differentials when you approach a patient of chest pain. So chief complaints can also vary and include abdominal pain, back pain, shoulder pain, sweating, giddiness, palpitation, syncope. So they might just come with a history of fainting episode or near fainting episode pre-syncope. Furthermore, presentations may significantly vary, and the most common life-threatening diseases you have to keep in mind. Okay, and less common life-threatening diseases also you have to keep in mind because they might have overlapping symptoms, and you might get confused when you are diagnosing ACS. You might diagnose an aortic dissection as ACS, and you can give medications like heparin, which you shouldn't at that point. So remember how important it is. I know I'm repeating myself, but it's very important to differentiate between these three diagnoses. That's why I marked in bold and in red, underlined it to place more stress on these three most common causes of chest pain, which causes the maximum mortality and morbidity. So you have ACS, pulmonary embolism, and aortic dissection. The common but less, less common but still life-threatening are the other causes: tension pneumothorax, esophageal rupture, pericarditis, and a potential cardiac tamponade. Remember, this is not, I will not go through all the causes of chest pain. I'm only going through the chest pain which I am worried about in my ED. The rest I'll hand over to Dr. Sudhakar, and Dr. Sudhakar will diagnose the other causes of chest pain. Okay, so I'm sorry. Just go forward. Yeah. So I've just to sum up my causes of chest pain, these are the 7 life-threatening causes of chest pain that you have to keep in mind while you are working in AED. Acute coronary syndrome, aortic dissection, cardiac tamponade, esophageal rupture, pulmonary embolism, pneumonia, pneumothorax. These 7 you are keeping in mind because if you misdiagnose a case, the treatment, the management differs a lot of each of them. So remember how critical it is to diagnose all of these very specifically. All right. So what are the initial actions of the primary survey? How do we go about a chest pain patient when it comes to ED? First of all, we determine if the patient is sick or not sick, depending on our clinical gestalt. So it depends clinically if the patient is looking to me sick or not sick. Obviously, there will be triaging by the nurses. So you assess the primary survey. The ABCs in emergency medicine doesn't go away. So the ABC doesn't stand for us for apple, banana, and cat. It stands for us for airway, breathing, and circulation. Even in our sleep, we can tell you ABC is airway, breathing, circulation. So airway, breathing, circulation, you assess these 3 first and vital signs of the patient, and then you categorize them as stable versus unstable patient. Obtain a focused history and examination and obtain ECG and rapid diagnostics. A very important thing is that when you assess the ABC, I'll tell you what is ABC in brief later. While you are doing all these, whatever I have mentioned, these steps, they all go simultaneously. Okay, it's not a vertical recess, meaning I am not the only person in my ED. So I have my colleagues, my nurses. So they help when I am taking a focused history. The other person is assessing the ABC and the vital signs. Another person is ordering for a ECG and a any rapid diagnostics which is required. One more person is counseling the patient attenders regarding what are the next steps to be done. So remember, it's a teamwork. Chest pain is a team sport. Simultaneously, with initial history, the team should also begin initiating the treatment and the diagnosis. Always take care of the pain of the patient. Give IV analgesics. Don't be stringent in giving the IV analgesics. Consider starting IV cannula oxygen if the patient is hypoxic or the monitor shows hypoxia. Initially, prepare for the worst. So remember, keep your instruments, crash cart, defib, everything ready. Never take a chest pain patient, even if you think that the patient doesn't look sick. Do not take a chest pain patient on a green zone. Always trash them to a red zone, because if the ECG, serial tropize, whatever you are doing comes normal, you can always wheel them to the green zone. Never take them first to the green zone. So consider placing a set of defib cardioversion pads on these patients who appear potentially unstable. So you should know the whereabouts of your ED. You should know where what is kept. It's not the responsibility of only the nurses to know where it's kept. It's doctor's responsibility, everybody's responsibility to know the whereabouts. Should you have a patient who presents in acute stress or cardiac arrest, remember while resuscitating the patient, you have to know the cause of the arrest. So remember your H's and T's. These H's and T's are usually taught in ACLS. So remember, if you have not attended a ACLS, please attend a ACLS. You'll get to know the H's and T's. Anyways, those are the same H's and T's which I have already included in my seven differentials for a chest pain. So remember, these are our airway, breathing, and circulation. Whoever is non-emergency medicine or non-critical care, it is helpful for them because airway, you do a chin lift, a jaw thrust, you place a airway, nasopharyngeal airway, oropharyngeal, or you intubate the patient. You buy time if you cannot intubate a patient, you are in a small setting or in a outskirts setting, then you can always use a LMA to help oxygenate and ventilate the patient well. Breathing wise, you can give oxygen. If it is a pneumothorax, tension pneumothorax, you can always do a needle decompression. Medications, keep ready your nitroglycerin and Lasix. BiPAP should be ready. Bag mask ventilation is a must, ambu bag. Circulation wise, you start with fluids. You always start with crystalloids. You never think of colloids here. So you always start with 20 to 30 ml per kg if the patient is in shock. You keep your antiarrhythmic drugs like amiodarone ready, adenosine for any arrhythmias, lignocaine for your arrhythmias, cardioversion, and defib should be ready. Your noradrenaline, adrenaline for pressors should also be kept ready. So usually, how is the presentation of a chest pain? Uh, Chest pain can come as retrosternal chest pain or left-sided chest pain, right-sided chest pain, just the shoulder pain, arm pain radiating to the arm, neck pain, jaw pain. All right, it can be anywhere, upper abdominal pain. So remember, your history taking is important and also as important as the clinical examination. If the patient looks to you ill, has high risk factors, then you have to think of the worst. Okay. Now, what we do in ED usually, if a patient presents to us with chest pain, serial ECG, serial biomarkers, we'll discuss it later individually. Clinical assessment, imaging, and observation is must. Never be in a rush to push off these patients as discharged patients or keep these patients in ward. Never be in a rush to dispose a chest pain patient. In patient with a high risk sheath complaint, remember the worst diagnosis to be considered first. So our three worst are ACS, pulmonary embolism, and aortic dissection. Even in our sleep, it gives us chills. Okay. So obviously there are other less acute possible causes which you actually, if you ask me, I do not care for them because I would diagnose my patients for them, but not initially. It's a diagnosis of exclusion for me than inclusion. So there are other causes. Very commonly, patients come to us with GERD, I mean gastritis, costochondritis, pleurisy, or simple anxiety attack. But remember never to think of these as the first causes. That's why I'm not at all highlighted them. Shouldn't come to your mind. However, arrival at a likely non-emergent diagnosis should only occur after evaluation. So this is just re-stressing about my point. Remember, in an elderly patient, ACS can just come present as generalized weakness. They can just come to you as general feeling weak, susto, and all that. And then suddenly you will have a scare when you see the ECG. So these are the classic symptoms, which are your retrosternal chest pain, breathlessness, excessive sweating. You have radiation of pain to jaw, to arm, to the other side of the chest. You have giddiness, you have palpitations, and you have syncope. Just remember, you would already know this. So I want to tell you something else. Simple rule of thumb which we follow in our ED. Exertional shortness of breath is usually serious. So keep your ears up when you hear shortness of breath, which is exertional. You should not exclude ACS just based on history. Do not go by that. That yesterday I ate fish, yesterday I ate something outside, and that's why I'm having chest pain. I'm very definite. I'm very confirmed that is just gastritis. It is never gastritis. Okay, until and unless proved otherwise. Clear lungs and hypoxia, think of pulmonary embolism. You have clear lungs, you don't have crepitations, you do not have any wheezing. Patient is still hypoxic, is tachycardic. Please think of pulmonary embolism. Put a well score, you'll know better. ACS, dissection, and P will fool you. Remember, please. All right, these are the symptoms. You guys already know this, but just to go through this, ACS, usually chest pain, as I said, only weakness, fatigue, nausea. Uh, Patient will usually be diaphoretic, ill appearing, can have crepitations. Pulmonary embolism, they usually come with a pleuritic type of chest pain. You have to put on well score or per criteria. They usually will have tachycardia, clear lungs, unilateral leg swelling, telling you that it's arising from a DVT. Aortic dissection will usually have sudden onset. Remember, the pain at the onset will be the most severe. So in aortic dissection, you can ask them, was the pain most severe when it suddenly occurred? And it's a ripping type of, somebody is tearing it apart, retrosternal or abdominal, anywhere. Chest pain, it can also come as lower back pain. Remember, there is a mnemonic called CP plus one. So usually in ER, we follow that for aortic dissection. It's chest pain. CP stands for chest pain plus one. So plus one can be any of the neurological symptoms, basically tingling, numbness, paresthesia, paralysis. All these can be one of the causes. Or CP plus one can be again chest pain plus syncope. Patient can just come with fainting episode and chest pain. Again, you have to think of aortic dissection. They would have an unequal blood pressure if the dissection has reached a point where there is a different BP. Remember, in the early stages, you might not have an unequal blood pressure. Okay, you might have equal and symmetrical pulses. There can be, but there can be obviously a low pulse, a low volume pulse on the other hand or on the other lower limb. So always look for radio-radial or radiofemoral delay. You'll have neurological deficit. They might not be able to move their lower limb. They might be, even after giving your opioids as pain medication, they'll still keep having pain. Tension pneumothorax, sudden onset again, severe unilateral pleuritic, usually seen, usually maximum time it's seen after a trauma. It can come with hypotension, unequal breath sounds, and tracheal deviation. Remember, tamponade is another obstructive shock where you'll have again chest pain and dyspnea. There's something called as Beck's triad. This is Beck's triad is basically this, that you will have muffled heart sounds, you'll have distended neck veins, and the patient will be in hypotension. Esophageal rupture, again, it's substernal, intense pain, but usually after a vomiting or an endoscopic procedure. So remember, mostly you'll always have Haman's crunch, which is crackle sound or heard whenever you, with respect to the heartbeat. So it very much mimics the ACS, but you'll always have a history somewhere presenting to you that the patient might have had vomiting and after that the pain started. Okay. This ECG, I think, is the most important diagnostic testing. Remember, in high risk patients, you have to get a ECG within 5 minutes of ED arrival. It's a quality indicator of your ED. How good is your ED? That you can order a ECG within 5 minutes and make sure that you look into it. Stand by the patient. Do not leave any chest pain patient till you get a ECG. Make sure that the patients are on cardiac monitors. Remember, the ECG, the first ECG can be as normal as possible. So always remember to repeat the ECG in every 15 to 30 minutes. Do not wait for an hour to repeat these ECGs. Please repeat in 15 to 30 minutes. I just shared a ECG which you might have a STEMI ST elevation MR, or you might have a patient presenting to you with arrhythmias. These are the evolution of myocardial infarction on ECGs. So you'll have a normal morphology. where the PQRS is normal, then you might start having hyperacute T waves. Then there will be a proper ST elevation. There can be Q wave and T wave inversion. So you can see a deep Q here, and the T wave which was positive here now inverts. The ST elevation improves here, and the T wave normalizes, the Q wave persists. So remember, this is the evolution of myocardial infarction on ECG, very important. It's also important that even though we read that S1, Q3, T3 is the most common, most specific presentation of pulmonary embolism, still sinus tachycardia is the most common one. So these are some of the ECG findings of the different causes in chest pain. In STEMI, you'll have ST elevation in two or more contiguous leads. In pericarditis, you'll have diffuse ST elevations with PR depressions and ST depression in AVR. In cardiac tamponade, you'll have this diminished QRS amplitude. You can have a electrical alterance as well. Excuse me. Pulmonary embolism, you'll have S1, Q3, T3, a sinus tachycardia, which is the most common, and you will have a right heart strain pattern. I think POCUS is the most important bedside test which we use. And this is used to assess the pericardial effusion, if there is any. A tamponade, it helps us tell us the contractility of the heart. It gives you the EF. It tells you about the IVC. Remember, while you are using POCUS, why I didn't say it's echo, because you use a POCUS, you use lung ultrasound as well. So lung ultrasound to rule out a pneumothorax bedside. So don't wait for a chest X-ray, please, to rule out a pneumothorax. Pneumothorax is a clinical diagnosis. You don't need a chest X-ray to diagnose it. You can use your POCUS and auscultation findings to diagnose a pneumothorax. Use portable screening of chest X-ray to rule out other causes, as we discussed. Remember, these are the most important, diagnostic testing which we do. Serial biomarkers, troponin I and troponin T, are critical to assess for ACS. Rapid testing at the time of clinical presentation, meaning at 0 hours and at 3 hours, help you plot the heart score, which is will help you in clinical decision rule. And remember, a negative D dimer in a low risk patient can help you exclude pulmonary embolism. So please, whenever you think of pulmonary embolism, always do a D dimer and plot your well score. There are many clinical decision rules. Okay. What we go by, I'm going to tell you something which you will always remember, a heart score. So we use in our ED every day. We do not discharge a patient without plotting a heart score, whoever comes to our ED with a chest pain. So clinical decision rules are very helpful in the management of suspected acute coronary syndrome, because history and physical examination is often not sensitive enough. So what is a heart score? I'll show you the heart score, then we'll go back to this. This is the heart score. Okay, so remember, heart stands for history. E is for ECG, A is for age, R is for risk factors, and T is for troponin. Now this troponin, whatever you use, troponin I, troponin T. History, if by the history it's highly suspicious, then you give 2. You give 1 if it is moderately suspicious, slightly or non-suspicious, 0. ECG, significant ST depressions, you give 2. Non-specific repolarization, 1. Remember, age is another factor. Where you have age more than or equal to 65 years, you straight away give 2 points. Risk factors. Now, what are these risk factors? Diabetes mellitus, current or recent smoker, hypertension, dyslipidemia, family history of CAD, even if the patient is not having CAD, but a family history of coronary artery disease. You can even have a cardiac arrest in the family. A sudden death is also a risk factor, and obesity. So remember, if the patient scores 0 to 3, the patient will have a probability of 30-day risk of major cardiac event. They will have a risk of 2.5% over the next 6 weeks. So you can discharge this patient home. So very minimal chance you can discharge these patients home. 4 to 6, the MACE would be 20.3% over next 6 weeks. So you admit these patients for clinical observation, serial tropi, serial ECGs, and urgent cardiology consult. 7 to 10, definitely MACE is over 72.7%. So early invasive strategies are required. So an urgent cardiology consult in the ED. Okay. So remember what were your cases were. So we'll just go through this. I have just 2 more slides. So the initial appearance on upon walking is that the patients are potentially sick, but they are not in cardiac arrest. Remember ABCs, you see vital signs. This is just to sum up what we learned. So ABCs and vital signs to determine if they're stable or not stable. Both the patients are awake and talking. So you ascertain that the patients are maintaining their airway. If they're speaking, that means they're maintaining their airway. So they're breathing, clear lungs, adequate work of breathing. So breathing is fine. Both patients have a normal blood pressure and an intact radial pulse with adequate perfusion. So remember, primary survey has been assessed and the patient looks not sick to you. ECG was obtained and ECG looked like, sorry, the ECG is not appearing well. That was a part of the ECG. This was the ECG, which is shown in the figure 2. So remember, it was a STEMI in both the cases. So the STEMI can basically to tell you that the STEMI can come with immediate symptoms, with urgent symptoms, and also symptoms lasting for last 24 hours for few days. So always remember to go through the history, the ECG, diagnostic, make use of your bedside test, diagnostic clinical decision rules like heart score. Always use your clinical markers like tropi. So to sum up, if the EKG is not diagnostic, a secondary survey should be done. Keep a broad differential initially. Try to formulate systemic differential. Always reassess the ABC. Even if you have reassessed once, please go and reassess the ABCs again. Patient might deteriorate while the patient is in your ED. Do not rely on a normal EKG and a normal tropi to rule out acute coronary syndrome. Do not rely on history to rule out a acute coronary syndrome. Clinical decision rules can be helpful, like heart score can be very useful for you to diagnose these chest pains. This brings end to my presentation. Thank you so much for listening. If there are any questions, you can please give it to the organizers. I'll be happy to take it up. Thank you.
Thank you, ma'am. Thank you for your Am I audible?
Yes, you are.
Thank you, ma'am. Thank you for your insightful presentation on approach to chest pain. The foundational insight you provided are crucial, and as accurately diagnosing chest pain can be often be the key to identifying serious and potential life-threatening condition. As you gave the example of gastritis, how we often ignore such symptoms.
Yes.
So your expertise and the importance of timely correct diagnosis cannot be overstated, and we are truly grateful for the knowledge you have shared. Thank you once again, ma'am. So
Thank
our
you.
chat box is open for the questions. So if anybody have any questions, please drop in the chat box.
ED, somebody asked me ED, emergency department.
Okay, so we have a very basic question. What is the meaning of ED?
It's emergency department, guys. Can we say ACS usually is a precipitant of heart failure? It can be. Thank
So
you.
actually, I'll take you to the question, Dr. Niharika.
Yes,
So
sir.
somebody has written, what about the well score? Well score, I will tell about in my talk. Indications for epinephrine and norepinephrine in acute coronary syndrome. You can just talk about it in short, Niharika, I think.
So indication of epinephrine and
So we have
norepinephrine.
couple of questions here.
Yeah,
So
I'll help her. Okay.
All right. So epinephrine and
Ma'am, how to
norepinephrine.
One minute. Let her answer, then we'll go to the next one. Yeah. Sorry, you can proceed, Nihari.
All right. So remember, epinephrine and norepinephrine. Basically, we use it
I
when.
was on mute.
Am I mute?
Can you mute yourself, Aisha?
There are many questions.
Yeah. So there are many questions. I think we'll have difficulty. Yeah. So if you don't mind, see about the well score, I will discuss in my topic in pulmonary embolism. Epinephrine and
Samriti ma'am,
yeah, I think we'll stick to the time. There are many questions. We'll take it one by one. And what we'll do is we'll keep answering it in the chat box. I think
Yeah,
that would be a good
that's
idea.
better.
So
That's
I'll take the lead and keep answering in the chat box, and my colleagues can help me too. I think this was a very elaborate talk by Niharika. I thank her for this coming on the Sunday and giving a talk. Chest pain is a very important topic, and there are various other differential, as she told. I think all the answers will keep answering in the chat box. Thanks, Niharika, once
Thank
again.
you.
We'll go to the next session. Over to you, Aisha. You can introduce to the next speaker. Aisha?